Good morning, everyone. So today I will be discussing about the bone marrow or mesenchymal stem cell transplant in the management of cirrhosis, where I will try to focus on the challenges in the management of cirrhosis and the indication for bone marrow or mesenchymal stem cell therapy. We will discussing more details about the bone marrow cell therapy in cirrhosis, what is the current evidence, and what are the challenges, and we will also discuss our own ILBS data that how the bone marrow response change in chronic liver injury. Then we will discuss about the mesenchymal cell therapy in cirrhosis, what are the indications, what are the outcomes with respect to chronic or acute liver failure in cirrhosis, and also our animal data which says that the use of UC-MSC therapy in management of immune dysfunction, injury and regeneration in ACLF. So coming back to the topic, that chronic liver disease, as we know that the incidence is rising with changing our lifestyles and leading to the development of cirrhosis, where these patients are more prone to infection and having surge, sepsis, shock and leading to their death. On top of that, if the cirrhosis they developed acute injury, the mortality is very high, and once there is a liver failure, the transplant is the only curative options we have. So, as we know that liver failure is a failure of regeneration, so we would like to first try to understand that what is happened for the liver regeneration when we are dealing with the chronic liver injury. So major challenge in the management of chronic liver injury is that these patients are having a progressive dysfunction and exhaustion of the immune cells, which is responsible for both the injury as well as regression of the injury, and this dysfunction lead to the uncontrolled liver injury, persistent fibroinflammatory response, and finally leading to the failure of liver regeneration. At present, there is no definitive therapy for any of this cause. Underlying pathophysiology is poorly defined. For immune dysfunction, yes, some immunomodulatory drugs has been tried, but it is largely ineffective. For management of inflammation or necroinflammatory response, some immunomodulatory drugs injury showed limited benefit. There are some experimental evidence using the bone marrow cell therapy or MSC. So bone marrow cell therapy till date it is shown some good effect, but the effect is very transient. MSC is safe, but efficacy of this MSC therapy has yet to be established. So when we see the liver injury and regeneration, so unlike the partial hepectomy where you have the remaining liver doesn't have much injury, so there is a limited role of bone marrow. But whenever we talk about the liver injury and then regeneration, the bone marrow plays a very important role in the creating a niche for liver to regenerate. So these bone marrow cells, basically they are having the hematopoietic stem cells, mesenchymal stem cells, endothelial progenitors, and the different type of immune cells. And these cells basically play a major role in the clearance of the damage. They provide the paracrine support for parenchymal and non-parenchymal regeneration. They modulate the matrix composition, and once they establish the niche component for the liver to regenerate, there is a start of hepatocyte proliferation by the cascade of signaling. Yes, in some cases when there is a hepatocyte proliferation is not able to compensate the regenerative response, the liver also try to ignite the progenitor cell response. However, the use of the exact role of these progenitor cells in recovery of the liver injury is still debated. And it has been shown in animal model that liver injury regeneration is always compensatory to the extent of injury. So as long as if you increase the injury, there will be the high regeneration, and this goes in linear fashion to some extent. After that, though there is not much change in the hepatocyte death, but there is a fall in regeneration, and that is basically leading to the regeneration failure. So this concept has been established in acute liver injury model. However, how this changes in the chronic liver injury is still not very much clear. Yes, based on the animal data and some clinical histological analysis, it has been shown that in case of chronic liver injury, there is a drastic change in the liver microenvironment in terms of fibrosis, the loss of regenerative signals, the hepatocyte senescence. So all these are thought to be the cause of poor liver regeneration in case of chronic liver injury. But the question remains that whether it is a hepatocyte senescence or loss of niche support before we start targeting them for the therapeutics. So I will try to discuss here is that whether it is a hepatocyte senescence or we need to modulate the niche. So initially there are report which says that in case of chronic liver injury or in case of aging of the liver, there is a telomerase shortening and the hepatocyte senescence. So they thought that this might be the reason for the poor regeneration in chronic liver injury. However, later it has been disproven and shows that yes, there is a senescence in the liver tissue, but these senescence are mainly contributed by the Kupffer cells and stellate cells, and hepatocyte doesn't show any kind of telomerase dysfunction with respect to aging. Later, the Liu et al. Has shown this, cleared this concept very nicely, and what they have done that they have used the normal liver, early cirrhotic liver, and the late cirrhotic liver. They isolated the hepatocyte from there, and then they transplanted into the healthy FAH mice model, and where they try to see that whether it is a hepatocyte dysfunction or it is the microenvironment which is the cause. Yes, these hepatocytes, when they isolated, they show the dysfunction in the telomerase activity or the senescence property. However, when they transplanted, there was not much change in the repopulation efficacy. And indeed, once they repopulated, they are basically regaining its telomerase activity. So this says that basically whatever the observed hepatocyte senescence, it is a transient, it is not permanent, and it can be reversed. So it is the microenvironment which is basically the major cause of regeneration failure in cirrhosis. In this cartoon, I would like to explain that what are the animal experiment evidence suggest and from where we will go for the bone marrow and MSC therapy. So as we know that in case of chronic liver injury, you have the hepatocyte death that basically lead to the Kupffer cell activation, and this will lead to the increased recruitment of the inflammatory macrophages in the liver microenvironment. These inflammatory macrophages, in one hand, it causes the activation of the stellate cells and leading to the fibrosis. This also leads to the chronic inflammation and innate immune dysfunction. There is a disruption of bacterial translocation, infection, and increased production of PAMs, which further causes the systemic inflammation and multi-organ failure. So now the different therapeutic cells has been tried to see that how we can modulate that. And the first one which people have explored is the hematopoietic stem cells. These hematopoietic stem cells initially believe that they are transdifferentiating to the hepatocytes. Later on, it has been shown that this transdifferentiation is basically whatever the signals we are getting that the donor cells are giving is basically some type of fusion from the native cells. But elegantly, later on, it has been clearly shown that these hematopoietic stem cells are not directly involved in the production of hepatocytes. Rather than the recruitment of hematopoietic stem cells to the liver niche, they ignite the recruitment of the other innate immune system to the liver, and they are shaping them towards more of a resolving in nature. And that these resolving macrophages are basically responsible for the regression of fibrosis, increase of regeneration. The second cell type that was tried was the mesenchymal stem cells. So mesenchymal stem cells in animal models says that it basically help in the switch of this inflammatory macrophage to pro-resolving macrophage in the liver microenvironment. It also lead to the production of IL-10, which inhibit the systemic inflammation. Recently, people have also started using the human monocyte-derived macrophages or the animal classical macrophages. So all this is basically trying to supplement this native resolving macrophage phenotype and lead to the regression of fibrosis and increased regeneration in animal model. So with this understanding, the clinical trial has basically started with the use of hematopoietic stem cells or the mesenchymal stem cells. Now coming to the use of bone marrow stem cell therapy in chronic liver disease, the indications, we have the defective resolution of liver injury, immune dysfunction and paralysis, defective liver regeneration. The cells usually used was autologous bone marrow hematopoietic stem cells. The aim is to ameliorate liver injury and fibrosis, accelerate regeneration, and restore immune function. Both in preclinical and clinical setting, there are 3 different modes has been tried. So initially the people were just using, so taking the autologous bone marrow aspirate, they just use after Ficol gradient centrifugation, they take out the mononuclear cells, which basically contains all these 3 types into this cell population. So they have hematopoietic, they have mesenchymal as well as the immune cell population. The second approach which has been done was the after Ficol, from this MNC, they sorted the hematopoietic stem cells and then it was infused back to the patient. The third, which is most widely used approach, was the GCSF, which naturally mobilize the native hematopoietic stem cells by various mechanisms, and that basically lead to the increased recruitment of the hematopoietic stem cells to the injured liver. So coming back to the trials which has used the unsorted bone marrow derived mononuclear cells, and mainly they use autologous bone marrow MNC, and they shows some improvement in the terms of liver function. There is only one study which they show they don't find any difference in the treatment or the control group. Then they switch to the CD34 sorted bone marrow cell transplant. Here also most of the studies shows there is an increase in the liver function and biochemical parameters. The most extensively used the trial of GCSF in chronic liver injury, and where the people have shown that they improve the survival, they have improved the liver severity index as well as liver function. And this is a recent trial from ILBS by Sastry that shows that use of GCSF in non-steroid responsive cases significantly improve the survival most, and then not only in the chronic setting, in case of acute setting like ACLF also, there are 3-4 studies which says that GCSF use improves the Mildes score, they improve the incidence of sepsis, SARS and other complications. And the study which I would like to discuss here, that the similar to the animal data, which people say that, so, but in human setting, the most of the mechanism of GCSF was not known. So in this study locus, which we have tried to see that how the GCSF changes the liver environment, and where we found that yes, when you give GCSF, there is an increased recruitment of the CD34 cells to the liver, that basically leading to the increase in CD163 positive macrophages in the liver macroenvironment, which is more of a resolving macrophage, reduction in the alpha SMA positive myofibroblast, and increased liver regeneration. Most important thing we found in this study was that yes, giving GCSF improve the Mildes score, but this improvement is only up to 9 months, and after that this vanishes. So this says that the use of GCSF, effect of GCSF therapy is a transient. More importantly, there is another finding also in this study was that the patients who are not responding to the GCSF therapy, they are showing a very poor bone marrow hematopoietic reserve. So that lead to so where Chagan has shown that during the progression of chronic liver injury, there is a loss of hematopoietic stem cells as well as the hematopoietic reserve. So yes, till date we know that there is some relation between the bone marrow and the liver injury and repair, but how this bone marrow dysfunction and liver regeneration are correlated to each other, that was not clearly understood. So we go back to the animal model to understand the kinetic change in the liver injury with respect to the bone marrow reserve. And here we developed an animal model which shows a progressive change in the liver injury. So our model, by week 3 we developed the inflammation in bridging portal fibrosis. By 6 we have the bridging fibrosis. By week 9 to week 10 they developed compensated cirrhosis, and by week 15 they developed the decompensated cirrhosis. So when we analyzed the liver injury, we found that from week 10 to week 15, which is the transition from compensated to decompensated cirrhosis, there is not much change in the fibrosis, but yes, there is a marked increase in the hepatocyte death. But unlike though you have an increased hepatocyte death, but the regeneration was gone down. So till week 10, you are seeing a linear increase in the regeneration with the increase in fibrosis. However, after week 10, there is a failure of regeneration. So we thought maybe that this failure of regeneration is associated with the development of decompensation symptom in these animals. Interestingly, when we look out their hematopoietic stem cells, so here the LSK is the population which basically define the hematopoietic stem as well as the progenitor cells. In animals, we can further classify them into the MPP, which is a multiple progenitor cells, which comes from the short-term hematopoietic stem cells, and the LTHSC is the most primitive form of the hematopoietic stem cells. So if you look at this graph, it clearly shows that so you have a regeneration failure between week 10 to 15. However, you have the bone marrow LTHSC loss between week 6 and week 10. So to somehow it suggests that there is this regeneration, the bone marrow failure precedes the regeneration failure. Now, when we look for the mesenchymal stem cells, the CFU is basically defining the stemness property of this mesenchymal stem cells. So that basically occur between the week 3 and week 6. And these mesenchymal cells are required to hold the LTHSC population in the bone marrow niche. So obviously then we thought that whether if we can correct the bone marrow, does it going to impact the liver injury? And for that we designed this experiment first to see that whether we need, because usually in the bone marrow transplant setting, we use the intravenous route for bone marrow transplant. We compare the two different mode, IV and the intrafemoral, where we are directly injecting the bone marrow cells into the bone. And when we analyze their localization with the time, what we found that the IV route shows less recruitment and they clear from both from the bone marrow as well as the liver very rapidly. However, when you give the cells into the bone, they show more recruitment both to the bone as well as to the liver, and their persistence is high. So that is the reason we next focus on the intrafemoral route for further study, and what we found that in comparison to control. So here I would like to emphasize that after 10 or 12 weeks of chronic liver injury, we stop the CCL4. So once you stop the CCL4, animals will try to regress its fibrosis. So in comparison to control, if you see that by week 7, there is no change in the bone marrow. However, by week 10 or week 11, when the injury has been subsided to some extent, there is some improvement in the LTHSC population. However, where the animals who receive the intrafemoral bone marrow transplant, there is a significant rise in the hematopoietic LTHSC population. Then we try to find that whether this rise in LTHSC population in response to bone marrow transplant is basically contributed by the donor cells or the recipient cells. So this was interesting to us that the rise, this green color is basically showing the donor cell population, and the gray color is showing the recipient own LTHSC population. So this clearly says that when we are transplanting the bone marrow, healthy bone marrow into the cirrhotic animals, so they are not much contributing directly into the repopulation, rather than they are inducing the native LTHSC to repopulate back. Similarly, we also try to find out the mesenchymal stem cells. Yes, when you give the bone marrow transplant, that significantly increase the CFU-F of the mesenchymal cells. And here you can see that the most of the colony which we get from after colony stimulation formation, they are basically the green fluorescent cells are in there. So this repopulation of the colony are mainly contributed by the donor mesenchymal stem cells. When we look at the liver, you can clearly see here that if you transplant the bone marrow, there is a significant reduction in the fibrosis, there is a significant increase in the liver regeneration, and also there is a significant improvement in the native F4/80, that is the Kupffer cell population of the liver. So not only in the number, their phagocytic function too. So then we try to see that whether if we continue the cirrhosis injury. So does it going to prevent the development of decompensated cirrhosis? So yes, we found here that once you give the bone marrow transplant and then you continue in the both arm, that the CCL4 induction is continue. So the animals which doesn't have the bone marrow transplant, they develop the decompensated like symptoms. There is increase in ammonia, creatinine level is high in these animals. However, animals who receive the bone marrow transplant, they shows reduction in this as well as the ascitic symptom. So in summary, this experiment tells us that during the progression of chronic liver injury, between week 3 to week 6, you have the loss of MSC that lead to the loss of LTHSC population, and finally there is a loss of hepatocyte regeneration and development of decompensation. If you intervene here with the healthy bone marrow transplant, that restore the LTHSC reserve, accelerate regeneration of fibrosis, potentiate regeneration, and prevent development of decompensated cirrhosis. Now, the next cell is the mesenchymal stem cells. So these mesenchymal stem cells are basically the adult or embryonic multipotent fibroblast like cells. So you can get these cells from any, so almost every vascular tissue, they are having the mesenchymal cells. And in clinically, the most prominent source are the umbilical cord, adipocytes, and the bone marrow. So these MSC, in physiologically, they are the stem cell for all the different mesodermal lineage cells like myocytes, dendrocytes, adipocytes, chondrocytes, osteocytes, fibroblasts, and osteocytes. So apart from acting as a source of these cells has been also shown that they have a tremendous healing capacity, and they call as the master healer of in case of physiological setting. So whenever you have a liver any kind of injury, so these cells which is present in the vascular tissue, they get activated and become mesenchymal stem cells. And once they become stem cells, they produce a huge amount of trophic factors, like in case of liver, it has been shown they have anti-scarring, anti-apoptotic, anti-mitogenic, they improve liver regeneration, reduce hepatocyte death, angiogenesis, decrease extracellular matrix. They also have a huge modulatory functions, so they modulate the function of both innate and adaptive immune system and decrease the inflammation and immune-mediated hepatocyte death. Now, people have also shown that this factor secreted by the mesenchymal cells also have various antimicrobial peptides. So in nut cells, once these mesenchymal cells are get activated, they try to restore a native liver microenvironment for regeneration and repair to occur. So with this tremendous healing capacity, there is a lot of interest in use of these mesenchymal stem cells in different setting of all the injury and including liver. So the first trial of using mesenchymal stem cells was initiated by this Muhammad Janad, and so this was in the first study they was trying to see that this impact only in the 4 patients where they have used the autologous bone marrow iliac crust puncture, and they isolated the MSC and cultured them in vitro, and after that they infused back into the patient. In this 4 patients, there is no side effect was observed. 3 out of 4 patients improve their model of end-stage liver disease up to 6 months, and 2 patients shows this improvement up to 12 months. With this trial, there are various trials has been completed using in case of the chronic liver injury, and except one trial which shows there is no benefit, they show some degree of improvement in terms of the ascites, edema, or liver function. So in 2018, they tried to summarize all these trials, which is mainly conducted in the China, Egypt, Iran, Turkey, and Korea. So out of total 1,540 recruited, 993 received the MSC, and the cell source was mainly bone marrow MSC in 19 study and UCMSC in 20 years. Route was mainly peripheral vein in 20, hepatic artery in 30, and portal vein in only 1. Sample size was 7 to 110, and doses was single in 23 study and multiple in 16. So in nutshell, these studies shows that MSC therapy improves MELD score, albumin, ALT, and total bilirubin level, as well as the prothrombin time of the patient with liver disease. However, no improvement in PTA, INR, and HE level was evident. The beneficial effect of MSC administration is not prolonged, and it is only a transient. Single administration exerted a greater beneficial effect than particular on the MELD score and ALT. Intra-arterial injection exhibited greater efficacy than in this meta-analysis. In terms of the complications, so fever, transient shivering, nausea, local pain, rash, and diarrhea, all these adverse events were resolved spontaneously. In 6 studies, they observed slightly increase in the gastrointestinal bleeding, primary peritonitis, hepatic encephalopathy in the MSC transplanted group. However, the 4th study doesn't show any difference in these complications. But though there is only 3 trials of MSC in case of acute injury setting of cirrhosis like ACLF, but this shows better benefit in terms of survival as well as the improvement in the liver function. So the first study was conducted by the Sai et al., which is basically a safety trial where they have used a 0.5 into 10 to the power 6 UC-MSC per kg body weight through cubital vein of the arm. And what they found is that the UC-MSC therapy group shows significant improvement in the liver function, decrease in the MELD score. They also shows that the UC-MSC group has a better regeneration in terms of AFP, and they have a better survival. The second study in ACLF was basically done in the ACLF, HBV-related ACLF patient who received the plasma exchange. So they divided this patient into 2 groups, one who received plasma exchange with MSC, 11 patients, and only plasma exchange in 34. And they tried to conclude that the patient who received plasma exchange with MSC, they have a better survival. The third study, which has a large number of cohort, so they recruited approximately 578 patients, and after exclusion, 130 patients were enrolled for this study. So 54 were in the SMT group and 56 was in the UC-MSC group. And this shows that the patient who received the UC-MSC has a better survival. Yes, in terms of complications, the fever is much more higher, incidence of fever is higher in case of group who received the MSC. So next, then we try to find out that how this mesenchymal stem cell therapy is working in case of ACLF. So I'm slightly deviating from my topic here to bringing the MSC into the picture here, that in one of our DST project, we observed that during the course of ACLF, usually people think that the increased inflammation and oxidative stress lead to the immunosuppression in these patients, in the innate immune system. And what we observe a new direction here also, that these increased inflammation and oxidative stress lead to bioenergy failure, and that loss of this bioenergy is basically responsible for the functional exhaustion of this monocyte. And these cells, when they encounter the secondary infection, they lead to the development of sepsis. And this bioenergy dysfunction was associated with the loss of mitochondria. So we thought that whether if we can supplement the mitochondria, and in the parallel, there are various reports which says that mesenchymal stem cells can donate its mitochondria to the injured cells. So in vitro, we first try to see that, so that here that if you co-culture the human umbilical cord mesenchymal stem cells with ACLF monocytes, it lead to the mitochondria transfer to the monocyte, increase the both functional as well as the total mitochondrial mass, leading to increased bioenergy and increased function. When we transplant this into the animal model of ACLF, indeed it shows that improves the monocyte bioenergy as well as function. And when we look at the liver, UC-MSC therapy, they decreases the hepatocyte ballooning within 24 hour and decrease in hepatocyte death. It also increases the Kupffer cell number in the liver as well as the phagocytic activity. It also improves the liver regeneration. So in summary, I would like to say here is that increased liver injury and regeneration failure with the transition of compensated to decompensated liver cirrhosis. Loss of hematopoietic stem cells precedes regeneration failure in progression of cirrhosis. Current approach of bone marrow cell therapy, like autologous bone marrow MNC, sorted HSC or GCSF are effective, but they are only transient effect, and they also need a preserved bone marrow HSC reserve. Allogenic healthy bone marrow transplant restore LTHSC MSC in cirrhotic, accelerate regeneration of fibrosis and regeneration, and prevent the development of decompensated cirrhosis. Mesenchymal stem cell therapy transiently improve the liver function in cirrhosis. Mesenchymal stem cell therapy significantly improve the liver function, regeneration, and survival in ACLF. Mesenchymal stem cell augment monocytes, bioenergy, and function, reduce liver injury, and potentiate regeneration in animal model. So based on the available clinical data and our preclinical study, I would like to convey this message. Might change in future. However, with the current understanding, it suggests that during the progression of chronic liver injury, you have the loss of bone marrow reserve, and that lead to regeneration failure and development of the pathology of the decompensated cirrhosis. And if you intervene with using a bone marrow therapy, so bone marrow cell therapy will be a better approach for the management of cirrhosis. However, if you have an acute injury and the development of ACLF, there mesenchymal cell therapy will be a better approach for the management of acute injury in cirrhosis. Our way forward is that with this preclinical understanding, now we are moving to the preclinical and clinical safety of healthy allogenic bone marrow transplant for management of fibrosis and regeneration in cirrhosis. We are also trying to develop the clinical protocol for effective use of umbilical cord MSC-based therapy for management of liver injury and regeneration in ACLF. I would like to thank Professor Sareen, Dr. Archana, Dr. Rakhi, Chagan, Dr. Mohanty from AIMS, Sukriti, and Dinesh. Human study was contributed with Dr. Rakesh and Dipanshu, and the animal study for the ACLF was done by the Nidhi, and all the bone marrow work, Dipanshu, and all the bone marrow work was done by Nidhi. And the financial support for this work was from SERV, Department of Science and Technology, Government of India. Thank you very much for your attention.